So my name is Gonsalves. I'm one of the staff members in the myeloma and dyspro group here at the Division of Hematology at Mayo. I don't have any disclosures to this talk that I'm going to be presenting today, and I'm going to split this up basically into three different phases. The first one's going to hit on myeloid malignancies. The second is going to hit on B-cell malignancies, but mainly chronic lymphocytic leukemia and lymphoma. And finally, I'm going to end with the talk looking at studies in plasma cell malignancies. And so there wasn't a whole lot in myeloid malignancies, but there were some key abstracts. In the interest of time, I'm going to pick a few, and in AML, I'm going to pick one, which is the ivosidenib in mutant IDH1 relapse and refractory AML. So, the genetic mutational landscape was really elucidated in AML almost, 5 to 6 years ago. And I think the year of 2017 has really been the year of acute myeloid leukemia and the number of FDA approvals for this disease. And it went almost decades without having anything approved. And so most people remember FLT3 mutations now being important in terms of midostaurin being used in combination with 7+3 in the upfront setting. But other key mutations involve IDH1 and IDH2. So both of these mutations roughly exist in around 10 to 20% of newly diagnosed AML patients. And this is key because enasidenib, which was inhibitor of the mutant IDH2 enzyme, was FDA approved this past year for the treatment of relapse refractory AML. Now, most people know that IDH1 and IDH2 somatic mutations lead to this gain of function in where you produce increasing quantities of 2-hydroxyglutarate, which is a known oncometabolite that has epigenetic functions, and it impairs cellular differentiation, and that's possibly one of the pathways taught to leukemogenesis here. So ivosidenib is a first-in-class oral reversible targeted inhibitor of the mutant IDH1 enzyme. And so what they presented was really an analysis of the original phase 1 trial in this study in relapse refractory AML of patients who had mutant IDH1 mutations. They combined patients from the dose escalation phase as well as the dose expansion phase that utilized the randomized phase 2 dose of 500 milligrams given once daily. And essentially what they did was they took cohorts number 1 and cohorts number 4 with the additional patients in the dose escalation phase that had